My name is Changi Kim. Today I am pleased to share our manuscript titled A Deep Learning Model Using Chest Radiographs for Prediction of 30-Day Mortality in Patients with Community-Acquired Pneumonia, Development and External Validation. Pneumonia is a major cause of mortality worldwide. Among various types, community-acquired pneumonia, which occurs outside of healthcare settings, is the most common. Predicting the prognosis of CAP patients is essential for effective treatment. Identifying high-risk patients in need of intensive care can improve their outcomes and decrease healthcare costs by reducing unnecessary hospitalization and invasive treatments for patients likely to have a good prognosis. To this end, risk prediction tools like Curve65 based on clinical indicators have been explored. Chest radiography is a vital tool for diagnosing CAP, as most CAP patients undergo chest radiography at the point of diagnosis. It can be utilized for risk stratification. However, incorporating chest radiography findings into a risk prediction tool has been challenging due to the potential for inter-reader variability in interpretation. Recently, deep learning technology has been validated and utilized in clinical practice as a diagnostic aid for medical images, including chest radiographs. Beyond detecting abnormalities or diagnosing specific disease, deep learning algorithms can also predict patient prognosis. Since the Government Republic of Korea recommended that the Curve65 score be used to assess CAP severity and monitors its utilization in institutions across the nation, the Curve65 score at the time of pneumonia diagnosis was consistently documented. The Curve65 score comprises 5 risk components. The purpose of this study is to develop and validate a deep learning model that predicts 30-day mortality in CAP patients using their initial chest radiographs, and we investigated the added value the deep learning model for the prediction tool Curve65. For the development of the deep learning model, we collected chest radiographs and clinical data of a total of 7,105 patients at a single center. Data were collected from patients diagnosed with CAP between March 2013 and December 2019, and baseline chest radiograph at the time of pneumonia diagnosis. In patients with multiple CAP episodes, data from the first episode were included. Patients with no information on 30-day mortality since CAP diagnosis were excluded from the study. The model was designed utilizing a Densenet 121 backbone and was trained by fine-tuning the pre-trained network. The pre-trained model that was used was developed to classify various conditions such as pneumothorax, tuberculosis, pneumonia, lung cancer, and normal growth from chest radiographs. The last layer of the model was substituted with a fully connected layer consisting of 191 perceptrons, with each perceptron corresponding to a 15-day interval of time. The outputs of the model denote the conditional probabilities of survival within these intervals. The figure illustrates the structure of the deep learning model used. For visualization of the model, GradCam was adopted. To improve the model's calibration, we conducted a logistic recalibration of the model output in the internal test dataset. Finally, to investigate the added value of the deep learning model for Curve65, we applied a logistic regression model that ensembled the deep learning model with Curve65 and compared its performance. The verification of the algorithm was compared through RC analysis for the performance of the deep learning model and Curve65. Using the results from the internal validation, We determined the operating threshold and calculated sensitivity, specificity, PPV, and MPV. We performed recalibration on the internal test dataset, and the calibration of the model was evaluated using the calibration plot and Spiegelhalter's z-test. We conducted external validation to confirm whether the algorithm's performance is reproducible in unseen data using separately collected data. And decision curve analysis was performed as an analysis method to evaluate this prediction model. Sensitivity and specificity show a trade-off relationship according to the threshold settings, and higher sensitivity increases the benefit of hospitalization of high-risk patients, but also increases the cost of false negative cases. This decision curve analysis can evaluate the relative value of benefits and costs associated with the prediction model. To validate the DL model, we separately included patients diagnosed with CAP after visiting the emergency department of one tertiary referral institution and two secondary referral institutions. The clinical information and demographics of test datasets are as follows. This is the result of internal validation in DL model. The 30-day mortality rate of patients in the dataset was 11.4%. The performance of the deep learning model was 0.835 AUC, and the calibration plot to the right of the figure shows that the mortality risk is being underestimated. Logistic recalibration was performed on the deep learning model for recalibration. The parameters of the recalibration results are as above. This is the result of external validation. The deep learning model showed consistent AUC in each external test cohort. The deep learning model showed a higher AUC than the CURB65 score. However, only temporal test cohort showed statistically significant results. At the same sensitivity level with a CURB65 score, the deep learning model exhibited higher specificity and PPV than the CURB65 score in all external test cohorts. Multivariate logistic regression was conducted to ensemble the CURB65 and the deep learning model. The validation results for the combined model are as follows. Like the deep learning model, the combined model showed a consistent AUC on each external test cohort and a higher AUC than the CURB65. The deep learning model and the combined model showed similar performance. This figure is the representation of ROC curve and calibration plot for the results. The following are the decision curve analysis results. The slower the left side of the graph falls, the more advantageous it is in terms of benefits to discover risks, and the slower the right side falls, the more advantageous it is in terms of cost. The deep learning model and combined model exhibited higher net benefit than the CURB65 score in internal test dataset and temporal test cohort when the benefit of hospitalization of high-risk patients is greater than the cost of hospitalization of low-risk patients. Chest radiograph in left figure shows diffuse consolidation involving the right lung. The risk of 30-day mortality predicted by the deep learning model was 42%, and the GradCam shows that the prediction of the model was influenced by the area of pneumonia in the chest radiograph. The CURB65 score of the patient was 2. The patient died 11 days after the diagnosis of pneumonia. Chest radiograph in right figure shows an area of consolidation involving the right lower lung field with right pleural effusion. The risk of 30-day mortality predicted by deep learning model was 9%, and the GradCam shows that the prediction of the model was not influenced by the area of pneumonia in chest radiograph. The curve 65 score of the patient was 4. The patient survived 30 days after the diagnosis of pneumonia. In conclusion, the deep learning-based 30-day mortality prediction model developed in this study also performed well in external test dataset compared to the existing risk prediction tool, curve 65. It is expected to improve management and risk stratification of patients with pneumonia. Thank you very much.